Thank you, Professor Yurdinov, for the invitation to take part in this session. So the topic I'm going to talk about is the place of the robotics in gynecologic oncology. Some of the themes will coincide with the previous lecture topics. So you know about the Da Vinci robot. Its name comes from the inventor Leonardo da Vinci, and this is his first invention, first robot. So he had some interest in the anatomy, and these two things can come together and make a great product. We have some paradigms in the minimally invasive surgery. So in this lecture, I will use this MIS term because in most of the cases, laparoscopy and robotics is almost the same as end results. What is it? Less postoperative complication than traditional laparotomy. That's why it's a very preferred one in most of the surgeries. In robotic surgery, we have S+, high definition, better view, enhanced instrumentation. In 2005, FDA issued the platform Da Vinci for gynecologic oncology cases, and then in 2019, again, FDA comes with the safety communication for the use in gynecologic malignancies. As this technique might have diminished long-term survival results. So we are going to talk about the different gynecologic cancers. And the first one is the cervical cancer. So as this one is the most controversial here, you should know it's the fourth leading cause for death cancers among women worldwide. And it's about 5,600 cases worldwide. The radical hysterectomy is the main way to surgically cure this type of cancer, and it's standard of care. So the first one who reported good result, not that good results, but this way of treatment was Wertheim in 1912. Then comes Vincent Makes with better results and more developed radical hysterectomy in 1952, and the Piver gave his classification of 5 types of radical hysterectomies. Then Coerleau and Moreau in 2008 made their classification, which is used now, especially when minimally invasive surgery is applied. You can see that further the associations of gynecology oncology in Europe is making some trials which aim to prove the results, the good results in less radical surgery and sentinel node biopsy in early stage of cervical cancer, 1A stage. Other type of radical hysterectomy is the total mesometrial resection of Hyokel, which says that less radical hysterectomy and more radical lymphnodectomy might have better results. So the added values of robotic hysterectomy are well known. And then on October 2018, came the prospective trial of Pedro Ramirez, the guy here on the lower picture, which says that the patients who underwent minimally invasive approach have a lower rate of disease-free survival, about 86%, compared to 96% for open surgery. And this study was prematurely closed because of unethical issues. And actually, this is the first prospective trial on this topic, and till now the only one which exists. After that, together with it, Melamed published another retrospective study from the National Cancer Database of the USA, which says again the same thing, but this counts for tumors which are bigger than 2 centimeters. The 1B1 stage is almost the same for minimally invasive and for open surgery. There are other studies which claim the same thing, which you can see down here. So almost all of these say that open surgery has better survival results, especially in cases with tumor bigger than 2 centimeters. So the specialists, the doctors, ask why this is happening. What can lead to such results? The first one is the effect of the CO2. So some say that this can spread the tumors around the abdominal cavity, or the CO2 can have negative effect on the peritoneum and can help for the tumor cells to implant in the peritoneal tissue. Other main topic is the use of intrauterine manipulators. So the introduction of the manipulator can lead to disruption of tumor cells and dissemination over the abdominal cavity. Köhler, which is one of the famous surgeons in Germany, made his study a big amount of cases. So he advocates that no manipulator should be used, and beside that, you can see on the picture on the left, he closes the vaginal cuff prior to the hysterectomy. So this is done vaginally, and he claims that his results for 3, 4, 5, 4.5 and 10 years disease-free survival and overall survival are above 90%. You can see it in them here. Then these authors made a retrospective study. It's a core study, and they saw that in cases with tumors bigger than 2 centimeters, the recurrence rate is twice as much as this in the open surgery, and this is not observed in tumors less than 2 centimeters. So MIS has lower overall survival than open surgery, and when talking about the manipulators, the disease-free survival is 73% in minimally invasive in manipulator group, then 83 when no manipulator was used. When protective vaginal closure was used in MIS, the authors say that 93% have disease-free survival in 4.5 years, and 74%, which is less when such a procedure wasn't done before. And about the LAC trial weaknesses, previous lecturer said something about this. So there are some things that are discussed as weaknesses of this trial, and these are the selection of the surgeons and the centers. Most of the surgeons were in the beginning of their career and with robotics, so it included the learning curves. Most of the centers were outside of the United States, so they say it's perhaps they couldn't be observed quite good. There were similar postoperative complication rates between the MIS and the open surgical hysterectomy, which is not consistent with the current data according to other studies. Only 16% of the patients were operated by robotics. All recurrences were in 14 of the centers. Some of the centers had a very low amount of cases per year. Besides that, the results for the abdominal radical hysterectomy were quite good, even much better than most of the reports till now. And what happened after the era of the moment of the LAC trial, we have some other studies which claim the opposite thing. So 2019, the Swedish nationwide population-based cohort study said that there is no survival difference between the robotic and open radical hysterectomy for women with early stage cervical center. And you can see the number of the cases. This is a retrospective, of course, retrospective trial. So the 5-year overall survival was 92% for miss and 94 for open, and disease-free survival 84% and 88 for the open and the miss, so quite similar. There is another retrospective big study, it's a South Korean one, which shows the opposite thing, that the laparoscopic radical hysterectomy has better overall survival. In 2020, a meta-analysis showed that laparoscopic hysterectomy is comparable with abdominal, concerning the disease-free survival and overall survival. And there are some benefits from the laparoscopic surgery. The Netherlands Cancer Registry with 1,100 cases showed that there is no difference between the two approaches when talking about disease-free survival and overall. And another New York study with lower number of cases, 200, showed no difference in 5-year survival. So this means that we need additional prospective trials, because as we know, the prospective trial is the most sure one. And these are, we have in the moment 2 ongoing prospective trials on this topic. The first one is the RAC trial, which is a Swedish one. It's an international multi-center trial, open label, randomized, and so it aims to gather about 768 patients and to finish on May 2027. Its primary objective is to assess the 5-year recurrence-free survival, and it has also some secondary objectives as quality of life, range of lymphedemas, node biopsy in women with early stage cervical centers. It's a sentinel node biopsy. And here in this trial, the use of intrauterine manipulator is not allowed. And the closure of the vaginal cuff is recommended, but it's not mandatory. The other trial is a Chinese one. It aims to gather 1,500 patients for 2 years in 28 centers in China. So the primary objective is the same here, but it aims to assess the role of the uterine manipulator as well, to see whether there are some tumor cells in the abdominal cavity. So this is a little difference. And what do the guidelines say about the use of minimally invasive in cervical cancer? ESMO says radical hysterectomy is performed by laparoscopy or robotic-assisted surgery cannot be regarded as the preferred treatment compared with open surgery in patients with cervical cancer 1A, 2, 1B, and 2A. ESGO, open approach is gold standard, and if you use MIS, you have to avoid spillage. NCCN says that again, because of the poor oncological outcomes, MIS techniques should be carefully consulted about the oncologic risks and potential short-term benefits of the different surgical approaches approaches should be discussed with the patients. Another important topic is the sentinel node biopsy in cervical cancer. So we have several studies here, Sentinel 1, 2, and 3. The first one was to assess the importance of this sentinel nodes assessment by sentinel blue dye and by technetium as a tracer. So this study showed that there is quite a good sensitivity, 92%, and very important negative predictive value, 98%. The Sentinel 2 study assessed the postoperative short and long-term complications, and the ESGO guidelines recommended sentinel in stage 1A without lymphovascular invasion. Small studies suggest a high diagnostic accuracy of sentinel node biopsy even in larger tumors. The Sentinel 3 study, which is aimed to finish in 2026, is aimed to assess the oncologic safety of sentinel nodes against pelvic lymph nodectomy with 3 years disease-free survival and quality of life. Another study, Sentix, assessed the 2-year recurrence rate of women subjected to sentinel only. So it's a Reddit study, and we can see that there is bilateral sentinel lymph node dissection over 90%. Frozen sections failed to detect 54% of positive pelvic lymph nodes, including 28% of cases with macrometastasis and 90% with micrometastasis. So it's quite sure that the frozen sections will not diagnose the cases with micrometastasis, and the majority of sentinels were located in the pelvis below the level of the vessels of the iliac bifurcations. What about fertility sparing surgery? The authors gave quite high fertility rate, 81%, following robotic radical hysterectomy, associated with low term of preterm deliveries. Recurrences are quite low, 4.5% and 7.1% when the procedure was aborted. Then we have some more reports about this of Nejat and authors who assessed other type of fertility sparing procedures, not only the robotics. And we have 2 ongoing studies, IRTA study, which is multinational, and the Chinese multi-center study on this topic. What about endometrial cancer, most common gynecological malignancy? Minimally invasive surgery is a gold standard for surgical treatment here. And we have the LAB2 study, which shows improved short-term outcomes, no difference in overall survival and recurrence, and a low conversion rate. And this study was not for robotics, but for laparoscopic surgery. Then we had LACE trial, and there was no difference in disease-free survival or overall survival when comparing open to laparoscopic surgery. Endometrial cancer in retrospective analysis was also quite preferred option, as it has better results, perioperative results, and almost the same overall survival and disease-free survival as the other open technique. Interesting data here is from the National Cancer Database, which says that in stage 2 endometrial cancer, the overall survival in robotic cases is 77%, 70 almost the same for laparoscopic, and 72 in the open hysterectomy. So we can say that the minimally invasive surgery doesn't reduce the values of these two important overall survival and disease-free survival. What about Sentinel in endometrial cancer? We know from the studies that there is no survival benefit when we are doing lymphadenectomy in early stage endometrial cancer. And as a Sentinel algorithm is introduced in NCCN guidelines from 2014. We have some other trials, as this one is the FIRST trial, which shows sensitivity of 97% and negative predictive value in 99%. And we know that the ICG Sentinel is much better than the blue dye Sentinel dissection, 90 against 64%. Very important here is the use of ultra-staging protocol, which I hope Professor Ivanova will say later if it's introduced in Bulgaria. As I know, it's not quite used. And it can diagnose the micrometastases. Why Sentinel? Because it reduces the operative time and also gives better the same diagnostic results. The injection site, usually we do it in the cervix, but it can be done hysteroscopically or in the fundus of the uterus. It's now the opinion is that the cervical injection is has quite good results, so the most surgeons do it so, even though the hysteroscopical injections gives better results for para-aortic sentinels. Failure of the sentinel napping might a reason for this might be change of the anatomy, radiotherapy, obesity, and a very interesting thing I saw here in the literature data is the one-step nucleic acid amplification, OSNA, which can potentially replace the intraoperative frozen section for sentinel lymph nodes, and perhaps this will be introduced in the future. Ongoing trials, 2 trials which are not finished yet, and which will show the value of the sentinel lymph node biopsy and for the end of the para-aortic lymphadenectomy at all in cases with intermediate risk. Para-aortic lymphadenectomy, it's in the FIGU staging. Routine systematic use stays controversial, and a CLAC trial started at March 2018, and its aim is to assess whether the systematic pelvic and para-aortic lymphadenectomy have significant impact on overall survival in patients with endometrial cancer in stage 1 and 2. Of course, in obese patients, it's sometimes quite difficult to do this technically. Obesity, this is one of the most important indications for robotic surgery, especially that obesity is a risk factor for endometrial cancer. In 2008 study, it was laparoscopy versus robotic surgery. So shorter operative time for robotics, less blood loss, and more nodes retrieved. It's a feasible option for super obese patients. And the authors say that in 85% of the patients overall and 67 of the patients with BMI more than 45, it's feasible. And quality of life, till 12 weeks of after the surgery, the advantages of miss persist, and after that, it's almost the same with open surgery. When talking about advanced cancer, there are some reports that robotic surgery can be used with total exenteration and so on. But I think that in most advanced cases, it might be useless. And the first picture is interesting because we can say it's advanced one, as there is a metastasis here from the endometrial cancer in the vagina. So this is a case, advanced case, which can be an option for robotic surgery. Ovarian cancer. Again, you can see the mortality, which is quite stressy here. But why and when we can use robotics and laparoscopic surgery, especially after a cytoreductive surgery, after neoadjuvant chemotherapy. So most of the authors claim that it's feasible. Even in half of their cases, Totsi said that they succeeded to do laparoscopic diaphragmatic peritonectomy. And in early ovarian cancer also, we can do omentectomy, we can remove the needed lymph nodes and so on, and especially in cases with high BMI, it's preferred type of treatment. So in a meta-analysis from 2022, robotic surgery and laparoscopic surgery had a shorter hospital stay, decreased blood loss, fewer complications, and the survival has no difference between the robotics, laparoscopics, and laparotomic groups. There is a study, a mirror study. So I think yesterday there was a online workshop, and the leading guy in this study showed his results, but I didn't find them in the web yet. And I think that large prospective trials with well-defined criteria are needed to assess the place of this surgery in ovarian cancer. And at the end, the take-home messages are that the robotics might overcome many of the limitations of the laparoscopic surgery, as the visualization and the ergonomics which offers this type of surgery. Current clinical data shows inferior oncological results concerning miss for cervical cancer. Because of this data and the encouraging retrospective analysis, further prospective trials are needed and are on the way. And avoiding the spillage of the tumor might be the key for unlocking the box of this controversial topic. MIS is gold standard for endometrial cancer, and robotics can add substantially in obese patients. Sentinel lymph nodes is introducing the precision medicine to the management of the gynecological cancers, providing comprehensive evaluation of high-yield lymph nodes, and the high-quality trials which we need for ovarian cancer is also another topic which must be discussed. Thank you for the attention.